Hey YouTube, I'm back with another video. My name is Dr. Daniel Kaplan and my mission is to make psychology accessible to all. In today's video, we're going to talk about genital pain and penetration disorders, right? In the previous few videos, we've been talking about various forms of sexual dysfunction, whether it be related to desire, excitement, or orgasm. Now we're going to talk about a condition that doesn't exactly fit into that mold, but can interfere with sexual functioning and psychological well-being. So without further ado, let's talk about genital pain. So as I mentioned, the concept of genito-pelvic pain and penetration disorders, they don't exactly fit into the specific phases of the sexual response cycle, but they do cause both physical and psychological distress. And this term, genito-pelvic pain and penetration disorder, or GPPD, is new, the term. And what the DSM-5 did was it collapsed the terms vaginismus and dyspareunia. These two conditions affect one's ability to have intimacy without pain. So vaginismus would be the involuntary spasm of the muscles surrounding the vagina area. And dyspareunia is more of a pelvic pain either during or after sexual intercourse. Now, to meet the criteria for GPPD, you need to have this condition for 6 months or longer with persistent and recurrent difficulties in one or more of the following: vaginal penetration, vulvovaginal or pelvic pain during intercourse or penetration attempts, fear, anxiety about vulvovaginal or pelvic pain in anticipation of sexual intercourse, tensioning or tightening of the pelvic floor muscles during or in an attempt for vaginal penetration. These features, at least one of them, have to be present for most, if not all, sexual experiences for 6 months. And I say that it has to be persistent or recurring because periodically there is going to be pain during sexual intercourse, and that could be due to a whole host of factors, whether it be the forcefulness of the act, whether it be the girth of the penis, things like that. Now, this condition also has to cause some form of a psychological distress, and it has to interfere with some aspect of function, usually romantic intimacy. So it causes relationship problems, but it cannot be better explained by something else like a partner violence or some medication issue, things like that. So what was vaginismus? The concept itself remains the same, even though the terms are collapsed into genito-pelvic pain and penetration disorder, right? Vaginismus, as I said, was the involuntary contraction of the muscles on the outer third of the vagina. And this condition doesn't have as much research as other issues, but we can estimate that less than 1% of women experience this issue. Most people view vaginismus as a learned fear response, so cognitive behavioral therapy could be useful in this regard. Some people might experience vaginismus as a function of some kind of infection or disease. Many people with vaginismus have other sexual disorders and or psychological disorders like panic disorder. So dyspareunia. Dyspareunia is characterized by pain in the genitals during sexual activity. we know that roughly 14% of women and about 3% of men suffer from this condition. So this is almost almost 5 times more common in women. Now, a typical physical cause could be some tearing or injury during childbirth, but there are psychological factors such as relationship problems or psychosocial problems that could contribute to this. Now, them alone, unlikely to cause the issue. I also want you to understand some health conditions that could result in genital pain or genito-pelvic pain. So things like endometriosis, pelvic inflammatory disease, interstitial cystitis, pelvic floor dysfunction, and fibroids, right? So these are all medical conditions that can cause pain during sexual intercourse and create some anxieties about having sexual intercourse. Okay, so now let's talk about treatments. There are some treatments. We mentioned that vaginismus, if it's the involuntary contraction or tightening of the vaginal muscles, thus closing the vaginal canal, we can use exercises such as Kegel exercises, using a yoni egg, things like that, which are practicing or teaching a person how to tighten and release the muscles of the vagina. And what started as an involuntary contraction, this person will eventually learn to gain more mastery or control over releasing the contraction during intimacy so that they can return to healthy sexual functioning. There's also a behavioral exposure to this. So there are vaginal dilators that are inserted starting really, really small and then getting larger and wider to the point where a person learns that, hey, it's okay for penetration, right? So ultimately, that the vaginal dilators do help. And I want to say about 90% of people, or most women, return to a pain-free sexual experience. Now with dyspareunia, it's a lot harder to treat because many times, unlike vaginismus, which has clear psychological anxiety factors or learned fear response, dyspareunia, you have to figure out, well, what's going on here? So if there's a physical cause or a medical problem, then a medical intervention, not a psychological intervention, would be necessary. So that is a very brief explanation for the concept of genito-pelvic pain and penetration disorders. As I said, you should have learned that vaginismus and dyspareunia were combined into one condition in the DSM-5. You should be able to identify the features of each, and you should be able to report several treatments for this condition. If you found this video useful, if you learned something new, hit the like button, subscribe, click the notifications tab. Also, if you found this video meaningful, leave a comment. I love when people leave comments. I read and respond to every comment. This turns us into a learning community. And if you have any questions, throw them in the comment section below too. Until next time, everybody, take care.